Hey, good evening, everyone. I think that's us going live now. Welcome to today's Mind the Bleep webinar on prescribing fluids. So today we have Lizzie and Anna here with us. Lizzie is an anaesthetics trainee, so is very well placed to talk to us about fluids. And she's going to take us through this really important topic. You can also read the article on the Mind the Bleep website, and I've put the link to that in the video description, so do check it out. Just a reminder that we're going to be recording this session. It will be up to view on the Facebook page, and we'll send out all of the materials if you sign up at mindthebleep.com/webinar-registration. Again, I'll put the link in the comments. Remember to ask us lots of questions. We'll try to get to as many as possible, but if we can't get to all of them, we will answer them after the webinar in the comments. We've also got a short feedback form at the end. It's really helpful for us to find out how these webinars are going. So please do fill it out, and you will also get a certificate of attendance, which is great for your portfolio as well. So Lizzie, we could just go on to the next slide briefly. Thank you. So before I hand over properly to Lizzie, just a quick shout out to our sponsors, the Medical Defence Union. It's really important not to forget to sort out your MDU Foundation membership before you start your shadowing period, because unless you filled in a foundation application form, your student membership will cease in the summer. And obviously, as you know, it's essential that you do have indemnity cover. So I'm going to put a link in the comments again, so you can join at the mdu.com/Lausanne. I'll put that link, or email our MDU rep with any questions. So that's all from me. Over to you, Lizzie.
Great, thank you so much, Niraj. We've also got Anna here, who's an F4 currently locum in. She's going to be chipping in as well with the comments, etc. So as Niraj says, I'm Lizzie. I'm an ST1 anaesthetics trainee currently working in A&E. And today we're going to be tackling fluid prescription. So hopefully this will be helpful for you all. So we're just going to think about why fluid prescription is important, which I'm sure you all know already. We're going to be thinking about fluid status examination and how to approach a patient who you need to prescribe fluids for. We'll then move on to looking at different types of IV fluids and when you might use them and the different ones available. And then we'll go through two different scenarios, so resuscitation fluids and also maintenance fluids. So first of all, oh, that's me again, hang on. There we go. So why is fluid prescription important? Well, firstly, it's one of the most common prescriptions you're going to do, both in hours and out of hours. I think even now as a trainee, as an SHO, one of the most common things I get asked to do is, can you prescribe some fluids, or could you do a fluid balance on one of my patients? So it's something you're going to be doing all the time, and it's good to have a bit of a background and feeling a bit more confident with them as you go into your F1 practice. The other reason it's important is that it's a drug, so there's a reason we prescribe it. As much as it has benefit for patients, there can also be can be harmful. So it's important to think about what fluids you're prescribing, how quickly you're going to prescribe them, and how you're going to reassess your patient as you go through. And I think the third thing is that fluid prescription was always a bit tricky. I think all of us have kind of rules of thumbs that we use to try and kind of get through and prescribe the correct fluids. But there's always going to be patients who are a bit more complicated, have multiple comorbidities, when you're sitting there scratching your head thinking, I'm not really sure what to do in this situation. And that's always going to happen. And it's good to have a bit of a background to think, how can I approach this? What do I need to think about as I go forward? But also asking for help when you need to. So let's start with the fluid status examination. So you're on call and you've been asked to review a patient who the nurses say, oh, could you give some fluids? They're not really eating or drinking. So whenever I approach a patient, the first thing is this person sick or are they well? So stand at the end of the bed and examine them from afar. The other thing to think about that I find helpful, both in clinical practice and in simulations, is this person compensating or decompensating? So is this person unwell, but their observations are holding and they're clinically stable? Or have I got a patient here who has an infection and is decompensating, or perhaps has a background of cardiac issues and is now in decompensated heart failure? So trying to distinguish sick, big sick, little sick is one way of thinking about it, compensated and decompensated. And then at the end of your fluid status, the purpose of the examination is the person in front of me hypovolemic, euvolemic, or hypervolemic? And each part of your examination is trying to address that so you can come to an answer at the end of your examination. So things to think about. So I'm just going to move this over so I can see what I put. So I, again, start at the end of the bed, have a look around. Can I see any vomit bowls, NG tubes, catheters, anything distinct that's going to tell me if this patient is clinically dry, has lots of fluid losses, or maybe they've got big Lucasades, lemonades, etc. that they're chugging on and are drinking really well. I then, with all my examinations, unless I'm doing an A to E approach, is I start peripherally. So what's their peripheral cap refill? What's their central cap refill? Are they clinically peripherally shut down? Then I move to the pulse. So what's the character of the pulse, the rate, the rhythm? Then moving on to the blood pressure. So hopefully that would be available to you, or you can look at the trend. But also, ideally, trying to get aligned standing can also be helpful with blood pressures. What I would say with pulse and blood pressure is to also take into account the patient in front of you. They might be on beta blockade because of cardiac arrhythmias or whatever. They may have multiple antihypertensive agents, or their baseline blood pressure may be much higher than the average, particularly in the elderly population. So not just looking at the discrete numbers themselves, but also thinking about, for my patient, is this a low blood pressure? For my patient, would I expect them to mount a tachycardia if they were significantly fluid deplete? Are they on bisoprolol, atenolol that might be masking a tachycardia? So once I've done pulse, blood pressure, moving on to let's get them to stick their tongue out. Are they really crispy? Have they got moist mucous membranes? Quickly looking at their JVP. Do I need to put pressure on the right upper quadrant to reveal the JVP? Or is it up to their ear and suggestive of heart failure? I have a quick listen to the heart sounds. Can I hear any murmurs, potentially any new murmurs from the last examination? Is there a gallop rhythm that might be suggestive of heart failure? And then I get them to sit forward if they can and listen at the bases for any crepitations that might be suggestive of pulmonary edema. While sitting forward, I have a look sacrally. Is there any pit and edema that I can pick up? And then move peripherally to look at any pit and edema in the legs. GCS is also helpful. So is this a patient you know who now has a deterioration in their GCS? Could this be someone who is delirious or has a cognitive impairment where trying to get an accurate fluid balance or history is difficult? And then ideally, one of the best things to get is a urine output. So are there bottles? Is there a catheter? Can we work out what the hourly urine output is? And if not, is this something I need to consider? Is a catheter going to be helpful? So as you're going through, a reminder to think, is this person decompensating or compensating? And is this person hypovolemic, euvolemic, or hypervolemic? And each point you should be thinking, how does this add to the picture of the patient in front of me? So by the time you get to the end, you can hopefully answer that question. Oops, I'm going to change. So once you've assessed your patient and you've answered your question, this is a hypovolemic patient or whatever you've come to, you then need to think about what fluids am I going to give this patient? So the two main ways we think about it is your crystalloids and your colloids. So if we start with colloids, these are fluids or fluid products that have large proteins or large molecules in, and they generally tend to address the oncotic pressures within the system. So gelifusин is an old example which isn't really used anymore. I don't think I've seen it in practice. That used to be used, but there was a high risk of allergy and anaphylaxis, so that's kind of gone off trend. Human albumin solution is another colloid that is sometimes used, can be used in resuscitation purposes. The most common reason I've seen it is for patients who have liver cirrhosis, who have acidic drains in situ, and who may require boluses of human albumin. Generally, you're giving it to patients who may be intravascularly deplete, but who you may be fluid or salt restricting because of different comorbidities. Again, it's not going to be a solution that you're going to use without senior or specialist input, so I have left that for there. The other colloid to remember is blood products. So it's important to think about blood products as fluids because you're increasing the intravascular space. Again, can be used for resuscitation purposes. So for patients who have got upper GI bleeds or major hemorrhages, or trauma patients, you may be using blood products as resuscitation purposes. But generally, we use that for, particularly on your wards, it would be for patients who are compensating with anemias, etc., that require slower blood product transfusion. The other side is your crystalloids. So your crystalloids are fluids that have smaller kind of salts in, and generally they affect the hydrostatic pressures in the intravascular system. So there's lots of different crystalloids, lots of different isotonic, hypertonic solutions. The most common that you're going to use unsupervised or more independently, let's say, is going to be your normal saline, so your 0.9%, your Hartmann's or Plasmolite, depending on your trust, and your 5% dextrose. What I forgot to mention is that this is a fluid lecture just for adults. I'm not a paediatrician, and I would not be in the position to teach you about paediatric fluid prescription. Even in A&E paediatric departments, I don't really go near fluids without paediatric support. So this is primarily for adults. So now we have thought about our different types of fluid, I hope that makes sense. Let's think about what's in them. I'm sorry for this badly edited slide. It took me a long time to work out how to put a table into this. So I don't by any means expect you to remember this table. This is just to have an idea of what you're prescribing. With any other drug that you prescribe, you have an idea of the pharmacology and the side effects, etc., of the drug. So it's important to understand what's in your fluids. So if we take the three main fluid types, I've picked Hartmann's just for ease over Plasmolite. So your sodium chloride is just salty water. It's got a much higher proportion of sodium and chloride than your Hartmann's. Hartmann's has got a smidge of potassium in, a smidge of bicarbonate, and is arguably more physiological. And then dextrose is just sugar. So bear that in mind, we'll come back to it at a later slide. So let's move on to resuscitation. So the people you're going to be doing resuscitation fluids are going to be your unwell patients. So your hypertensive and or tachycardic patients, patients who are potentially septic, and patients who may be bleeding, so hypovolemic patients. Again, the main things we give are crystalloids. As I said before, there may be purpose for blood products as a resuscitation resource. Again, it's important to think about that that is still a fluid. So if you're given fluid side by side, if it's a resuscitation scenario, it may mean that you need to give both at the same time, depending on what's available. But generally, if I was on the ward, if I was in resus, I'd generally be going for crystalloids. So either your sodium chloride, your normal saline, or your Hartmann's or Plasmolite. I think resuscitation fluids are a bit easier to get your head around. So generally, you're going to do boluses, and you're going to be picking 250 or 500 ml, depending on the patient in front of you. If it's a well patient, so a young patient, minimal cardiac or renal background, or no cardiac renal background, who's a good BMI, reasonable size, who you're not concerned about overloading, then I would go for 500 ml. If you've got someone who's maybe a bit frail, has a poor functional or physiological reserve, has a cardiorenal background, then I'd go for 250. And you're going to bolus that over 15 to 20 minutes. After each bolus, you're going to reassess. And the point of the reassessment is to repeat your fluid status, but also to think about, is this person responding? Are they transiently responding, so they pick up and then they go down again? Or are they not responding at all? The reason for that is to judge your next step. So am I going to give another fluid bolus? They've picked up. I'm going to keep going and give them another bolus before I reassess. Are they transiently responding? So I need to be, keep an eye on them and give them another bolus, and we may need to go down a different route. Or are they not responding at all? Maybe because I'm not keeping up with the fluid losses. There's a bleed that I'm not picking up. Or this is a person who is so sick, we might need to get intensive care involved to review them for vasopressor support, etc. Now, generally with boluses, you tend to go for up to 4 boluses before you get to the kind of the maximum point where you think, well, if it's not working, we need to think of a different route. And then you go into a middle ground of, I've done my boluses, they've had 1 litre, 2 litres. Now I need to give them, I call it the middle ground of resuscitation and maintenance fluid. So someone who is septic or has, had a bleed, if you stabilise them with your resuscitation fluids, then you're going to think about giving them, maybe a 6-hourly, 4-hourly, 6-hourly, 8-hourly bag, depending on what they look like. The thing with fluids is that it's a bit of an art, and it's based on experience and confidence as well. But whatever you prescribe, the key is always to reassess and see what the fluids are doing and how the patient's responding. The beauty of fluids is you can adjust them as you go. You can go faster and go slower. But the main thing to take away from resuscitation is bolus, reassess, and thinking about how your patient is responding to that. So let's do a case. So we've got a lovely little lady from Google here who is 84, lives in a nursing home, and has come into A&E, you're the F1 Clarkin, with 2 days of confusion, a temperature, and malodorous urine. So just looking at her examination, just have a quick read through and see what you think. I appreciate I don't know who's watching this. I hate there's people watching this, but just have a quick read and see what you think. And whether you think this is a patient who is going to need resuscitation or maintenance fluid. There's a clue in that we have just done resuscitation fluids. But it's an 84-year-old female from a nursing home. So from a nursing home to me suggests someone who is potentially frail, has a poor functional or physiological reserve. We've got 2 days of confusion, temperature, smelly urine, so UTI, delirium, something to think about. If I have a look at that examination, so we've got someone who is tachycardic, hypotensive, febrile. They're peripherally shut down, clinically dry, with no signs of clear overload. So in this lady, particularly, let's say this is our lady. She's, frail. Even from the nursing home, we know that her reserve is going to be poor. We don't know anything about her background. We're still waiting for bloods, etc. So I think with this lady, she's firstly going to need resuscitation and need boluses because she's hypotensive and tachycardic. So with this lady, I would go for a 250 milliliter bolus of normal saline. I prefer normal saline because there's no potassium in it. I know there's only a smidge from what we've seen, but without knowing what their baseline potassium is, I prefer normal saline, but it's up to the individual. And I would bolus this over 15 to 20 minutes, and I would reassess following that bolus. The other point of this is that her urine output is unknown. So I think next week there's a lecture on AKI and managing that. But firstly, this is a septic patient, so you're going to be following your sepsis 6 and catheterizing. But one of the most helpful ways to know is this person responding to my fluid boluses is their observations and also the urine output. So trying to get an idea of what they're passing is important. So for this particular example, I would do 250 ml of sodium chloride, 0.9% over 15-20 minutes and reassess. I'd probably do 2 or 3 boluses. And if she's responsive, I'd then move on to probably a 6 or 8 hourly bag of sodium chloride or plasma light, depending on her response.
Hi, Lizzie, just to ask a quick question here.
Yeah,
We've got a few people asking whether you would give the fluids over 15 minutes or whether you would give it just stat. And also people are wondering about the cap refill. Is the cap refill under 2 seconds or is it over? And does that influence the fluids?
Fine. So let's say the first thing was the stat versus 15-20 minutes. Yeah, I mean, 15-20 minutes is a ballpark. I think if you try to run fluid stats without a pressure bag, it probably would be a similar time frame anyway. Pressure bags can put it through much faster. So in this lady, I'd probably just do 250 ml on full flow, and it's about 15-20 minutes. If you've seen the devices that you use, so you've either got the one that turns and it gives you calculate mil per hour or mil per minute, I think, and you can do it more accurately. Or you have the ones which are just a rolly and you put it on, I just tend to put it on open flow and let it go through. The pressure bags, you can put the fluid in and pump it up, so almost like a blood pressure cuff, and that will go through much faster. So I think it depends on, if I had a young patient in front of me who was deteriorating and had a low blood pressure like this, I'd probably even put 500 ml or even a litre and put it in a pressure bag and pump it through quickly. I think it's important to think about the patient in front of you, the risk of overload. But generally, if you say to a nurse, can you give that over 15-20 minutes, they're going to put it on open flow. So it's not really about timing it. It's, I mean, I think it's variable depending on, firstly, the cannula you've got in, the access you've got, the type of kit that you're using, on how fast it will go through. So I wouldn't get too hung up on 15 to 20 minutes. Stat 15 minutes is basically the same. And then the other thing you said was about cap refill. Is that right? Hello?
Yes.
And what
Sorry, I was muted.
That's okay. What was the question in terms of?
People are just wondering whether this influences your decision if the cap refill is over under 2 minutes, what kind of fluids to use then?
So I think with the cap refill, the things again, you're not looking at one isolated thing. So you're using it to build up a picture of the patient. So if someone has got a peripheral cat refill of more than 2 seconds, so if you're talking 4, 5, 6 seconds. So this lady's got a peripheral cat refill, so from her fingers, of 4 seconds. Blood is being diverted away from the peripheries to go centrally because they're starting to decompensate. So I think what peripheral and central cat refill tell you is how sick is the patient in front of me. Now, obviously, if you've got someone who's got Raynaud's or is cold or whatever, that's going to affect the cat refill. So I wouldn't never take any of this really in isolation. You need to think about the whole picture. But what peripheral cat refill and central cat refill tell you is what's the distribution of blood in the body and are they starting to peripherally shut down? So if you've got someone who has their heart rate's fine, their blood pressure's fine, they're drinking some water, they've got no peripheral sacral edema, but their cat refill is is 3, 4, 5 seconds, I'm not necessarily going to rush in with fluid boluses because the clinical picture is not telling me that's a hypovolemic patient. If I've got someone in front of me who, yes, has a peripheral cat refill of 4 seconds, is dry, is hypertensive, tachycardic, and drowsy, then that's pushing me towards a hypovolemic picture. So you're not taking things in isolation, as with anything in medicine. You're taking each part and putting it as an argument towards what your overall answer to your question is. Does that help?
Yes, that's great. Thank you.
Perfect. So hopefully we have that case presentation has been helpful. Again, it's a one-off presentation. I'm happy to go through other scenarios if you need to. But this is a scenario where you might adjust and go for a lower volume for your fluid bolus. Then we get on to maintenance fluids, which we were discussing just before this talk, can be quite tricky. And as I said, with fluid prescription, it's a science and an art, and a lot of experience and confidence can help with prescription. So the people who are given maintenance fluids to are people who are nil by mouth, so they may have a reduced GCS, they may have, they're waiting for salt assessment because they're at risk of aspirating, they may be for elective surgery. They may have reduced oral intake, so have a bit of gastroenteritis, they're trying to drink and eat a bit, but it's by no means matching their overall targets. Or they may have electrolyte abnormalities, so you need to replace potassium or their magnesium and do it a bit faster than oral routes. For example, if their losses are greater than their intake, or if perhaps they're not absorbing, so you wouldn't give them oral potassium, you'd go for IV potassium. Again, we're going to go down the crystalloids route for your maintenance. So it's your sodium chloride, Hartmann's, or your 5% dextrose. And then we get onto the bit which I think people find difficult. And I still find difficult. Even today, I was sitting in A&E debating with myself what maintenance fluids to give. There's no right or wrong answer. Again, the most important thing is whatever you prescribe, you are reassessing and watching your patient's response to it. So this is when we get onto the formula. So the NICE guidelines state that this is the 24-hour requirements for maintenance fluids. So for a healthy individual who's not eating or drinking. So we're aiming for 25 to 30 ml per kilogram per day of fluid, so water. For your potassium, sodium and chloride, it's 1 millimole per kilogram per day, so it's easy to calculate. And then your glucose, you're aiming for 50 to 100 grams per day of glucose. Now don't get too worried about this. I can even sense through Zoom that there's some panic. Nobody panic. So let's take an example because it's much easier to do it in practice. So you're the surgical F1, you're out of hours, and a 36-year-old lady has come in and she's got an elective cholecystectomy tomorrow. You've been told by your reg that, oh, she's going to be nil by mouth from tomorrow night, so can you prescribe some fluids? She's clinically well, her obs are fine, she's euvolemic from your fluid status examination, and she weighs about 80 kilograms. So let's apply that to our formula. So if we look at what her recommendations for water, we're talking about 2 to 2.5 litres of water a day. It's about 80 millimoles of your potassium, sodium and chloride, and again, 50 to 100 grams per day of glucose. Fine. Let's apply that to, oh, it doesn't work, our, what's in our fluids. So I think we were talking about this before the lecture started. This is a rough guide. I think it's helpful in terms of understanding what quantity or what volumes of fluid you're going to give to your patient. So with this lady, 2 to 2.5 litres a day, that's a helpful guide. I think it's helpful in terms of making you recognise that you need to think about potassium and think about glucose, not just giving salty water. But if you look at the graph, so we can see from the sodium chloride and the Hartmann's, there's an awful lot of sodium in there. So for this lady, we're aiming for 80 millimoles of sodium. Well, unless you're going to give her loads of dextrose, you're always going to overmax your sodium. In terms of potassium, you've got a smidge in your Hartmann's, but there's no, it's 5 millimoles. You can't add potassium to that. So your options to provide potassium is to give potassium chloride and add it to bags of either. So you can add it to your sodium chloride or to your dextrose. With your potassium, you can add 20 to 40 millimoles per bag. And they're your main routes of providing IV potassium. Again, you can give Hartmann's, but recognizing that it's only going to be a smidge of the potassium requirements for 24 hours. And then in terms of your glucose, so 1 litre of glucose gives you 50, so your lower end of normal of your glucose requirements. As I said, it's a bit complicated. So let's apply this. Oh, actually, I'm going to go back. What have we done? This. So what we need to do is just have a quick think. There's no right or wrong answer to this, but just for a minute, have a think of what would you prescribe this patient. So some of you may have heard of the salty sweet, etc., but try and think about how am I going to get 2 to 2.5 litres of fluid into them, either via sodium chloride, Hartmann's, or dextrose. How am I going to match their potassium, sodium and chloride needs? Again, sodium chloride, you're probably going to over-egg, but how am I going to get that potassium in them? And then how am I going to balance giving them some sugar as well? So if you want to, you feel free to write them in the comments. I can't see them, but Anna will be keeping an eye. If you don't want to, that's fine. Just have a little think about what you would do. Again, no right or wrong answers. So thinking about what solution you would give, how are you going to get the potassium in, how are you going to get the glucose in, and then how fast are you going to give those fluids? It's tricky, but just have a go. I'm going to keep an eye on the clock and give you a minute or so. And if there's any questions in the meantime, I'm happy to answer.
Hi Lizzie, just a quick question that's come through on the chat that actually I've always wondered about too. So somebody's just asked about 4%, glucose, 0.18% sodium chloride. So I think that's called dextrosaline, isn't it?
Yeah, so I think the difficulty with those as well is thinking about if it's isotonic, hypertonic, etc. Generally, those I wouldn't prescribe those without senior's advice, just because it's also complicating the sodium, the potassium. You need to think about what their baseline sodium potassium is. So I don't know about you, Anna, but I've never prescribed anything other than 0.9% or Hartmann's or 5% dextrose. The only times I've prescribed maybe hypotonic or hypertonic saline is in the context of hypo or hypernatremia, and that's generally under the advice of endocrine and or ITU.
Yes, I agree. I don't even think the normal wards would have it like readily available. You'd have to go looking for it. It wouldn't be something you would find quickly.
And again, I think when you're thinking about when you're prescribing fluids, again, I think there's hypo and hypernatremia talks as part of Mind the Bleep, but you need to be aware of what you're not only putting, because you're putting sodium chloride in, what shifts that's going to have with your potassium and your sodium, etc., and how that's going to affect your results of the next couple of days. So I would even, I certainly wouldn't be comfortable prescribing anything other than these three, purely because of predicting the response to those fluids, not only in terms of fluid balance, but in your shifts of fluid from one compartment to the other based on the sodium potassium, if that makes sense. So in theory, yes, but in practice, I think if you asked a nurse to find you a 0.18% or whatever, they would look at you blankly and ask you to prescribe something else. But certainly maybe in intensive care settings, etc., that may be a different story. So let's have a look on this word example. So I'm giving a suggestion. This is not right, this is not wrong. This is something that I came up with. So I'm going to give 2 1-litre bags and then consider giving a 1/2 litre. I'm going to spread my potassium in 1 bag of sodium chloride and 1 bag of dextrose. So my dextrose, 1 litre, is going to give me my 50 grams glucose. My sodium chloride is going to give me more than enough of my sodium and chloride. Plus, I'm going to add in some potassium chloride over my 2 bags. So again, bear in mind, there'll be a bit more chloride going in as well. So for this patient, she's young. I'd probably give over 8 hours. It doesn't matter which bag you start with, it's up to you. And then depending on her response, you can speed up, slow down the fluids as you need to based on what she's looking like and what her obs are doing. And you can also, if you wanted to top her up to the 2.5 litres, the options I thought were to give either half a bag of sodium chloride or half a bag of dextrose. Note that in the 500 ml, I'm avoiding adding any potassium. You can add potassium. I'd probably add maximum 20 millimole, but generally I find it easier to put the potassium chloride in the 1 litre bags. So that's one option. I'm happy, I can look through the other suggestions later if anyone's put anything there. Not right or wrong. As I said, I think this formula is helpful, in thinking about the volumes you're going to be given. So in this lady, you know, you're only prescribing 2 and a bit bags. You're not going to be going, you don't want to start pummeling her with 2 hourly, 4 hourly, 6 hourly bags. It's going to be too much. It also is making you think, which I think is forgotten sometimes, is that they will have potassium and glucose requirements as well. Now, I say the caveats are, firstly, if this is a lady who's coming in for an elective cholecystectomy, she's probably not going to be nil by mouth for 24 hours. So actually, do you need to be prescribing all the bags? There's always anaesthetics complications, things that delay lists. So it's important to think of, you know, what you would give, and you may want to prescribe them in the background. If she's going to theatre, she may have fluids down there as well, which you're not prescribing. So this is when the formula is perhaps less helpful in real life, because unless someone is going to be completely nil by mouth for 2, 3, 4 days, which they shouldn't really be without thinking about their nutrition, you're not necessarily going to have to prescribe all of these bags of fluid. The other caveat is, again, you're going to reassess after each bag. So if you're on a normal 8-hour shift and you're prescribed a bag of fluid, I would at least halfway through or towards the end of a shift, eyeball the patient or have a look at the ob just to make sure that you're providing the right amount of fluids. The other thing to think about is if we go on to the more challenging patients. So the elderly, as always, are going to be a bit more, you need to be a bit more wary about what you're prescribing. Equally, if the patient's got a higher proportion of body fat to muscle, then you don't want to go just on their actual weight. You want to think about their ideal body weight. So someone who's going over 100, 110 kg, there's formulas to calculate their ideal body weight, and I would go by that rather than the weight on the scales. The other thing to think about, renal impairment and heart failure. So even someone who is perhaps dehydrated or intravascularly deplete, if they have a background of renal impairment or heart failure, then you just need to be a bit more cautious or a bit more wary of how you're prescribing it. I would tend to go a bit slower for maintenance, so not resuscitation, for maintenance side of things, and assess more frequently. And again, you're assessing by doing your fluid status, what's their observations doing, how much urine are they passing. And this is when communicating with the nurses is important, because you need to have good input-output charts to make sure that what you're doing is, and what the patient is responding to, is reflective of actually what's happening. And then the other thing to think about is actually with the potassium, particularly if you're adding potassium in, you need to be keeping an eye on what the salts are doing. You don't want to over-egg it with potassium. Generally, if you're adding potassium in, it's not going to overshoot particularly someone's not eating or drinking, but you do need to keep an eye on it. The reasons you may need to increase the amount of potassium you're given, or think about other salts like magnesium or calcium, or think about giving fluids a little bit faster, is if you've got ongoing electrolyte losses or fluid losses. So is this person having ongoing diarrhea and vomiting? So if you think briefly about potassium, if someone's got potassium of 3 to 3.5, generally I'd give oral replacement. If you've got someone in front of you who is vomiting with a potassium of 3, 3.1, 3.2, my inclination would be to start going on down the IV fluid route of replacing the potassium, because that's the main way. First, you're going to keep up with their losses of both fluid and electrolytes, but also absorption of oral supplements, and that may not be optimal. So having that in the back of your mind of, do I need to increase the speed or the volume of what I'm replacing? Does this person, have they come in bowel obstruction and they've got a Riles tube in and they've got high output from their Riles tube? Have they got a stoma that's having high output losses? Or is this person being NG tube fed and actually the dietitian has worked out their overall requirements, and they're having flushes potentially with medication that I need to incorporate into my maintenance? I remember as an F1, I had a patient who was not eating or drinking orally, was having, I think, an NG tube. I think the NG tube is actually in for medications, and they were starting to think about NG tube feeding. And it was a tricky balance between thinking about maintenance fluid in that bridge, but also remembering that they're having flushes. So whenever medication's being put in, they're having 50, 100, 200 ml flushes that are going through. And there's a consideration of actually, could I increase their fluids by increasing the amount of fluid with the flushes rather than going IV? So NG tubes are something that to think about, and having discussions with dietitians and nurses about what's actually going into the NG tube is really helpful. Other things that may require faster electrolyte replacement or IV fluid is things like pancreatitis, where they have high amounts of third spacing and they lose lots of fluids and they may need to have it quicker. Hemorrhage, so do I need to think about giving blood products? And another one I thought of was potentially like DKA. So there's very clear guidelines in your trust about DKA replacement. But in certain cohorts, so for example, in younger patients, you need to be cautious about fluid balance, as you can cause cerebral edema. Again, if in any doubt, and these are complex patients, always ask. I still ask if I get stuck. But it's just to build up a picture of the patient in front of you and how the maintenance fluids may be more complicated. So you can see how, although that formula is helpful, it has a lot of caveats, and you need to make sure you're thinking, if that's your skeletal of what you're aiming for, is there anything that's affecting it, and anything that might mean that I give more fluid or I need to tweak it. What I would say for elderly patients is, I think if we just go back, we've said 25 to 30 ml per kilogram per day of water. For the complicated patients, so the patients who are at risk of overload, if they're frail, elderly, cardiorenal backgrounds, I think the recommendation is 20 to 25 ml per kilogram per day. The rest is the same, but that's just to bear in mind. So as I said, with maintenance fluids, it's tricky. Now, this is the NICE guideline, which I don't think any of you can read. I can't read it, but this is what to look for when you Google. This is the flowchart of what is recommended, so evidence-based. It tackles your fluid resuscitation, so giving boluses, and then it also goes down the route of routine maintenance for your patients who are nil by mouth and their overall requirements, but then also caveats to that and when you need to think beyond that. Now, when you go to the wards, I can guarantee you that if you ask for advice from SHO's registrars, they may not be calculating it from this. They may be going from experience. They may be saying, "I'll give an 8 hourly, give a 10 hourly, reassess." Again, that's not wrong. And it may be that that's coming from seeing lots of patients, prescribing lots of fluid, and kind of subliminally coming up with, knowing in the back of their mind what that patient's going to require. Some people prefer just giving plasma light, particularly if it's a short period of time they need maintenance fluids. And again, that's not wrong. It's just that when you're doing the prescription, make sure that you are reassessing and understanding what your patient's needs are so that you can keep up. So generally my rule of thumb, and this is not something to necessarily follow, is that if I'm doing maintenance fluids for elderly patients, I will tend to go 8, 10, 12 hourly. Normally I'll go a bit slower with the 10, 12 hourly, and I reassess more frequently. For younger patients in maintenance, I might do 6, 8, 10 hourly. But again, that is very broad, and it's based off of me prescribing lots of fluids. And again, I would not be prescribing without looking at my patient, eyeballing them, and thinking about what caveats there are to that. So ultimately for maintenance fluids, what I would say is, if you're stuck, use the formula and think about what's this person's normal requirements if they were well, and etc. Are there any caveats to that? Do I need to give it faster or slower because of their background? And is there any electrolyte abnormalities that I need to think about? Do I need to think about their magnesium and replace that for their potassium? And is there anything I need to particularly monitor as I go through? The maintenance is more difficult. And again, it's always going to be a science and an art. And the more you do, the more confident you'll get. But don't let confidence turn into complacency. You must always reassess your patient and make sure that they're responding how you're anticipating they will. So as I've said about 50,000 times in this talk, always reassess, 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 reassess. If in doubt, reassess them more frequently. It's time consuming, it doesn't have to be. The more you do it, the quicker you get, but it will give you more confidence that what you're doing is working. You can tweak things as you go. And remember that the nurses are your assets, they're your eyes and your ears. You can't be sitting there next to your patient watching the urine drip into the catheter bag. You need to be reliant on them to alert you if there's a problem. So making sure you're documenting, please can we have accurate input output monitoring. This is what my targets are. And if there's any problems, do bleep me. So what I recommend is doing your regular fluid assessments, looking at, so utilising bloods. So particularly if you're doing electrolyte replacements, make sure that you are doing, I would say, daily bloods, particularly potassium, and making sure you know what their baseline is. So FBC can be helpful with a CRP for infection markers. Also hematocrit can be helpful to see if they're dry or if they're dilution, there's dilutional effects. Bone profile, so again, that's more to do with firstly the nutritional status and also to do with thinking about potassium, etc. So do I need to replace something else before I replace the potassium, normally magnesium? And your LFTs are helpful, again, mostly for a nutritional status and looking at the albumin. The urine output that the formula we tend to say is 0.5 ml per kilogram per hour. So in our 80 kilogram polycystectomy patient, we're aiming for 40 ml an hour. In our little frail lady who might be 40 kg, we're aiming for 20 ml an hour. Again, that's a guide. So what I tend to write is we are aiming for, so urine output monitoring hourly, aiming for 40 ml an hour. If less than this for 2 consecutive hours, bleep me. Because there's going to be some high, dips and troughs, and you're looking at average overall. Remember to have caution in complex patients and patients who, particularly the elderly, and having a look at, is this patient at high risk of me pushing to overload? Do I need to think about electrolyte losses? And is there something that might be tricking me? Are they on multiple antihypertensives, beta blockade, that might be complicating the picture in front of me? And the most important thing, regardless of your stage of training, if you're an allied health professional, if you're an F1, if you're a consultant, it doesn't matter. If you're in doubt, ask. We all have periods where, particularly when you're fatigued, it's like you come up with an answer. And there's particularly times as an F1 where I sat there and I sat there and I sat there and I tried to work it out. And actually, if I just asked my reg, I could have learned a bit from it. It would have been much quicker. And I can always reassess as we go. So see what your colleagues say, see what the nurses think, have a conversation and look at the whole picture and come up with a management plan. And whatever you do, just make sure you're reassessing your patient as you go along. So I hope that's helpful. If there's anything that was clear as mud or you want me to go over, just let me know in the comments. And I will hand over to Niraj and Anna. Thank you.
Hi Lizzie, it was great. Thank you, very great. I learned a lot. Just got a few questions if that's all right. So one of them, which was a very good question from Mohammed early on, was if a patient's quite unwell, how do you do a line and stand and blood pressure? And would it actually add anything to the clinical picture?
So I would, in that situation, I think a line standing blood pressure is helpful as a helpful adjuvant to your clinical examination. So the reason I use it is if I'm in the A&E, there's a patient in the waiting room who's describing some diarrhea, vomiting symptoms, and actually the observation's okay, I'd ask for a line standing blood pressure because sometimes that can reveal a dehydration that we're not picking up. If I've got a patient in front of me who is hypertensive, tachycardic, peripherally shut down, not passing urine, a line standing blood pressure, firstly, is probably going to be dangerous. You don't want them to tank their blood pressure more than it already is, and it's not going to change your management plan. So it's a helpful adjuvant to what we're doing, but it's by no means, again, an isolated thing that you're going to rely on. The other thing you can do to assess fluid response, so for example, if you need to assess if your patient needs fill-in, so if you're given boluses, etc., is that you can tip them, so lift their legs up or tilt the bed. And if there's a response in their blood pressure or their heart rate, then it's suggested that they would benefit from fill-in. Again, I don't recommend going in and tipping the patient upside down. But sometimes if they're really hypertensive, that can guide you as to are they going to be fluid responsive, and maybe it can get the blood pressure up and help them cerebrate whilst you're trying to resuscitate them.
Perfect, thank you. The next question we had that was asked by a few people was, what's the maximum amount of potassium that you can give over an hour?
Good question. So I think on the ward, it's 20 millimole an hour. No, 10 millimole an hour. In ITU and with central lines, it can be 20. So if you're giving potassium replacement, firstly, you're never giving potassium replacement as a resuscitation measure. If you're giving IV potassium, it's 10 millimole an hour. So if you want to give 40 millimole, the fastest you can give is over 4 hours. And again, if you have an unwell patient in front of you, I would not be adding potassium chloride to anything to resuscitate. I'd be using my Hartmann's or my sodium chloride to increase their intravascular volume. And then you can do quick maintenance fluids. So if you need to replace potassium relatively quickly, you've resuscitated them, but you're worried they've got ongoing losses, you could do a 4-hour, 6-hour bag of potassium chloride, that's fine. But making sure, the reason for that is that you don't trigger arrhythmias, or you can get extravasation and cause irritation to the skin, etc., from adding potassium chloride. So 10 millimole an hour on the ward is the fastest you can replace potassium. Don't use it for resuscitation measures. If they need it faster, then it's discussions with seniors for potential central lines in ITU.
Okay, perfect. One question that was a little bit tricky is, what is the ideal resuscitation fluid for a hypertensive chronic liver disease patient?
So again, your cirrhotic liver patients are the reason that, they're the complex patients. They're one of the complex patients because they're likely to have low albumin. So without having albumin in your intravascular system, whatever you put in is likely to leak into your third space, which is why you get the ascites and peripheral edema. So again, if you have a sick cirrhotic patient, so liver patients who are sick are really sick, and they can go off quite quickly. I would go for 250 ml boluses of sodium chloride whilst escalating to a senior, because again, it may be that they need PAS or they need specialist intervention. So because whatever, with cirrhotic patients, whatever you're putting in, if they have low albumin, they're going to third space and they're going to remain intravascularly deplete. So in those situations, sometimes HAS is used, but again, it's you're just artificially replacing the albumin that they're not synthetically making. So liver patients who are decompensating, it's better to get early senior advice in because they can become unstable quickly. So again, if you had someone who's at risk of heart failure, who is hypertensive and you think is dry, I would still go for 250 ml boluses, because the problem in front of you is that they are intravascularly deplete. But there's always going to be that tricky thing of, I could push them into fluid overload at any point. And it's, you can start doing simple measures by doing small boluses and seeing how they respond. But in all these complex patients, I would escalate early.
Okay, perfect. We had a question with regards prescribing fluids and whether you would go for 8-hour, 6-hourly bags. I know there's not much difference between the two. I don't know if you found any difference in your experience.
I think what I found helpful sometimes is to calculate how much you're given per hour. So for example, if you think of, if you're giving someone 250, well, let's say 500 ml boluses, so a young person. So really over an hour, by the time everything gets set up and triggered in, you're giving a litre over an hour. So if you think about a 4-hourly bag, that's going to be 250 ml per hour. So you're going into smaller boluses. So if you try and break it down, so let's do the maths because it's past, I'm post nights. So let's do, so you're doing, so 6-hourly bag is 166 ml per hour. 8-hourly bags will be 125 ml an hour. So actually there's not a whole lot of difference between it. Again, you don't need to, once you stick to your fluid resuscitation, you don't need to never touch it again. You can speed it up, slow it down, work out what the urine output is. I tend to go for kind of 6-8 hourly in younger patients, depending on how dry they are. There's no right answer to it. I would slow it down much more in the elderly who are stable, who need some maintenance fluids. But again, if you think about 6 to 8 hourly or 8 to 10 hourly, there's not a whole lot of difference over an hour, which is why reassessing means that, if you reassess after 2-3 hours, not a whole lot of a difference is going to have gone through by that point and you have time to adjust it. I also find it more reassuring if you calculate it per hour, just because then if you think about a can of Coke's 230 ml, a 6-hourly bag is 166 ml. So if you think of actually how much is going in, it does make me feel a bit better, particularly when it gets to 12, 14-hourly bags, etc. But again, you know, there's no real difference. It's all about the reassessment and how your patient is responding. You may do an 8-hourly bag and you need to speed up to a 4-hourly bag. You may do a 6-hourly bag and slow it down to a 10-hourly bag. Again, it's finding a starting point, being safe in your practice and reassessing as you go.
Definitely. Another question we had was with regards how often you would need to take bloods for the person who's receiving maintenance fluids.
So I think that is more to do with why they're requiring maintenance fluids than what you're given. So if you have someone who is nil by mouth for an elective surgery, it's probably going to be your routine bloods that you're going to do preoperatively. If you've got someone who needs maintenance fluids because they are an aspiration risk and they've just come in and you haven't made a decision about NG tube, then you're also thinking about what's their renal function, what's their potassium doing, what's their nutritional status from their potassium, their calcium, magnesium, etc. So I think probably more frequently. Equally, if you've got someone who came in with an infection, they're not septic, but you're giving some maintenance fluid to try and support them whilst they're getting through their infection, perhaps because they're sweating and they're losing fluids that way. Your bloods is more in response to what they're doing with their infection rather than what's my fluids doing. I would say the caveat to that is if someone's got an AKI or if they have a background of CKD and you're worried about potassium. Again, if someone's got a potassium of more than 5 as a baseline, I probably wouldn't be adding much potassium in, particularly if they've got a background of CKD. So I think my answer would be, depends on what the cause of the maintenance fluids is. If there's something you're particularly worried about in terms of, most likely it's going to be electrolytes that you're adding or replacing. So if you're giving fluids to someone who has a low sodium, a high sodium, a low potassium, a high potassium, I would do at least once or twice a day, particularly high. So patients with low or high sodium, I get a bit probably overprotective of, and I do twice a day sometimes if I'm worried about overcorrecting. But that's more of a lecture on salts and electrolyte replacements than general fluids. So there's no correct answer to it. Be guided by your team and what your consultant's practice is. But it's more in relation of why you're giving the fluids rather than the fluids itself. Would you agree, Anna?
Yes. Sorry, just a few more quick questions we've got. How do you calculate replacement fluid in dehydration and the maintenance?
So I guess if someone is clinically dehydrated, firstly, do they need resuscitation? So do you think, let's give them some boluses and see how they respond to it. I would tend to, I think if they're dry, then you're thinking about what their losses are. So this is not, the formula that we've got is for patients who haven't got extra losses. So why are they dehydrated? If it's because they're not eating or drinking and we haven't replaced their fluids sufficiently, that's one reason. Are they dehydrated because they have profuse diarrhea and vomiting, and that therefore it's going to be beyond what the calculation is? So I think the formula for the maintenance fluid, it's helpful to think, if this person was well in a 24-hour period, what would they need? So say 2.5 litres. Okay, this person's now got profuse diarrhea, vomiting, and I know that they're losing 500 ml a litre in fluid. So you're probably going to be aiming for 2.5, 3.5 litres. But again, I wouldn't never prescribe 3.5 litres and walk away. I'd probably give a faster bag. So say if you've got a young patient, diarrhea and vomiting, clinically dehydrated, but kind of stable-ish, I'd give a 4-6 hourly bag. I'd reassess whilst that bag's going to make sure they don't need boluses or faster fluid, and then see where you are at the end of that bag. Have you given antiemetics? Have you worked out the cause of the diarrhea? Have you managed to slow things down? And do I need to give another fast bag? What's their urine output? Actually, they're passing loads of fluid, they're passing loads of urine. Let's scale back and maybe give an 8-hourly bag, 10, and review from there. So again, there's no strict measurement, but I think if you calculate what your maintenance and what your goals are, and then what your losses are or what the input is, you can kind of make a balance. But again, after each bag, you just need to keep reassessing, because when you're prescribing, you're trying to predict your patient's response, but then you need to make sure that that is matching their actual response. Would you agree?
Yes, definitely. I would be very nervous prescribing 3 litres and then walking away.
Particularly, there's a temptation over weekends, I think, to just try and help the on-call team out and just prescribe your fluids. I would do that cautiously. If you're going to do that, I would put them on the handover for someone to check that that is appropriate. Particularly if it's if it's going to be 48, 72 hours between you seeing your patient next, I would be very cautious about prescribing multiple bags of fluid without reassessment from yourself or someone else.
We just have a quick question. What is the usual fluid to give in sepsis?
So if someone is septic, then you're thinking, so sepsis is an abnormal response to an infection. So you are going down your sepsis 6 protocol. So see if I remember them. So you're doing fluids, giving oxygen, giving antibiotics, and you're taking blood, lactate, and urine, I think. So in someone who is septic, by definition, they are unwell and they are decompensating by definition. So I would go down the resuscitation stage. So if they are hypertensive, tachycardic, febrile, I would go down the fluid boluses. Remember, someone can have an infection and not be septic. So again, what's the fluid balance? Are they eating and drinking, etc.? But if realistically, if someone is hypertensive, tachycardic, you giving them a bolus is firstly required, and secondly, is going to cause a whole lot of problems because they're intravascularly depleted.
Okay, that's great. And then would it be possible just to go back to the worked example that we had? There's just a few questions wondering if we would be giving the patient a little bit too much potassium.
Potentially. So I think if we go to the worked example, so they're aiming for 80 millimoles per day. So I think if we go to I mean, that's 80 millimoles over, what, 16 to 24 hours?
I think also the question was a bit about if you were to give them Hartmann's, would you overload them with potassium? So I actually answered it in the comments, but we wanted to double check with you that if you give Hartmann's as a maintenance fluid, you can't add any potassium to it, can you?
No.
So that means that you might not be giving them enough.
No, so I mean, if you look here, on Hartmann's, it's 5 millimole per litre. So 1 litre, you're not going to be meeting their potassium requirements. I used to love giving Hartmann's and Plasma Light. And I still do go down that route if I've got someone who is eating and drinking. It's just to give them a bit of a boost on top of things. But if I've got someone who is nil by mouth, who is not, they're not getting any salts in, I don't think your Hartmann's is going to match their requirements. It will match them for, the sodium potassium will be fine. But there's hardly, although there is potassium in it, there's not enough.
Sure, and there's also some lactate in there as well, isn't there?
Yeah, I think in Hartmann's there is. I don't think it's a drink.
Is that relevant in the context of sepsis? So with the question that we just had about fluids and sepsis, would you be about that, or is it okay?
I don't think so. I think I would say if you're thinking about what's in a litre of fluid, I would say it would be negligible. I don't know off the top of my head, but I certainly wouldn't not give, if I had a septic patient in front of me and I only had Hartmann's, I'd give them some Hartmann's. Again, the counter argument is, if you had someone who was dehydrated in front of you, would you give them a cup of salty water to chug? Probably not. Diurolite isn't just salty water, it's got some potassium and stuff in it. So the counter argument is, if you're giving someone copious amounts of normal saline, you can push them into metabolic acidosis because you're shifting their anion gap. So the counter argument is also true of, you don't want to keep throwing loads of sodium chloride at them, and sometimes giving them some dextrose as an alternative. I probably, Hartmann's is going to have the same effect. It's still got a significant amount of sodium and chloride in it. But sometimes, particularly for patients who you've given quite a lot of fluids to, particularly if there's like an endocrine background, so they're DKA, HHS, sometimes with the insulin in the background, you can switch them onto dextrose just because you're avoiding the anion shifts with the sodium chloride. But again, don't get too bogged down in that. You'll never.
I can tell you do anesthetics.
Well, you spoke about earlier loosely. I'm in my first year at ACCS, so I haven't actually done the anesthetic.
Very interesting physiology there.
Yeah.
So yeah, Anna, if there are no more questions coming through on the chat, anything to add to anything Lizzie said?
I don't think so. I think she just did a really good job, covered everything, really. I learned a lot.
I agree. I learned so much as well. Thank you so much, Lizzie.
Cool.
Yeah.
So everyone who's still watching, we've actually still got quite a few people watching. If you do have any more questions, then do feel free to just comment on Facebook. Lizzie or one of the team will get back to you with some answers. But thank you so much for watching. I think we had about 400 people at the peak. So that's 400 more people prescribing fluids very well. So thank you so much, Lizzie and Anna. You both did a really good job, and everybody else, we've got an AKI webinar coming up next week. I know some of you were asking about AKI, and obviously it ties in very nicely with this topic. So make sure oh, you're doing that one too? Yeah. So if you want to see more of Lizzie next week, then
I will be offended if you don't show up, but it's fine.
then do come by for the AKI talk. So just go to our Facebook page and click events. Just a reminder, this is available to view again, and so are our previous lectures. So if you want to look at electrolyte abnormalities and things like that, then do have a look, and take a look at the associated article as well. I've put the link in the description. So if that's all from everybody, should we call it a day? Great. All right, thanks everyone. See you next week.